Next slide, please. Good morning, dear students. We have dealt with various conditions after dealing with the anatomy, physiology of the nasal cavity and the paranasal sinuses, and some of the disease processes and their complications. Today we'll go to a condition which is called epistaxis. Epistaxis, in the sense, it means bleeding. Epistas or something like that. In German it is called bleeding from the nose. So it has been derived from that. Now this epistaxis is bleeding within the nasal cavity, and this is only a symptom. It's a symptom. It's not a disease as such. So the causes of this epistaxis, or bleeding from the nose, are usually classified into idiopathic, local, general. And idiopathic, usually we put that term when we do not know the exact reason or we cannot identify the exact reason for the bleeding. And they form usually to the tune of 55%. Then we go to another condition which is called local. Local in sense just at the site where it is, that is from the nose or the paranasal sinuses. Some kind of there are several conditions that have been listed. We'll go to that list a little later. But usually these are the problems usually classified as a congenital, then traumatic, inflammatory, neoplastic, and various other conditions, anatomical variations which can give rise to local bleeding. Then we go to another heading which is called the general. General in the sense it is the blood. Anything related to the disorders of the vascular system, usually related to the deficiencies that are present in the blood clotting mechanism, or various other conditions, pharmacological, or the drugs which produce some kind of a bleeding tendencies in the blood, and things like hypertension. So next we go to the, as I told you, the local various conditions which can give rise to bleeding from the local causes, nose and paranasal sinuses. These are, as I told you, usually classified as traumatic, usually nose pricking. This nose pricking is the one which is quite a common factor, which is particularly more in summers, because the mucus secretions, when they come in contact with the hot air, becomes crust. These crusts are there attached to the nasal wall, either to the septum or to the lateral wall, and there is a tendency, because they produce some kind of irritation, you would like to take them out. And this is quite common in children, this nose picking, but sometimes even it may continue into the adulthood stage. Then of course the facial injuries, the traumatic injuries, when you have a fight with your friends, husband, wife, or the teacher, or when you are into active sports like boxing, or rough games like the football, there are chances that there is a facial injury. Then of course the foreign bodies, which are quite common in children, because they would, they are very inquisitive. They would like to see what we usually eat through the mouth, and then it goes into the stomach. So they would like to explore. There is another opening here in the just above the mouth. So if I put something here, where does it go? So this inquisitiveness is the one which is quite common in children, and so they try to put all kinds of foreign bodies, starting from the chalk pieces, erasers, and seeds, like that. So that is as far as the foreign body is concerned. Then the inflammatory conditions, which are quite common, because the first thing, usually the source of infection is airborne or droplet infection. Somebody coughs on your face or sneezes. These the droplets that are present in the atmosphere are inhaled by you. So nose is the one which is directly exposed to the outside atmosphere, and so the infection usually enters the nasal cavity. Then you have other conditions like the allergic rhinosinusitis, nasal polyps. Then another heading is the neoplasia. Neoplasia is a tissue which is growing without any purpose, and they are usually classified as benign and malignant. And of course the tumors which are in relation to the malignancies, they have a tendency to bleed more. And then you have the vascular, the congenital conditions, hemorrhagic telangiectasis, and some of them acquired like the Wegener's granulomatosis. Then you have these iatrogenic which are produced by the surgeons themselves. That is, surgery, you have undergone some kind of surgery on the nose septum terminates, and so they start bleeding. And the nasal, sometimes you try to introduce a nasal gastric tube into the nasal cavity, through via the nasal cavity for feeding purposes. That can traumatize the nose and produce. These are all iatrogenic. And then the structural, wherein the spurs, acute spurs, are nothing but acute angulations at the junction between the bone and the cartilage. And of course the septal perforations, where which has been dealt with, where the air passes through the nasal cavity, and the mucus secretion becomes thick and forms crusts, and when these crusts are either removed, when they fall down, they produce ulceration on the mucous membrane and start bleeding. Then of course there are drugs, the nasal sprays, which are sprayed with a little pressure, with a little force. So when they are continuously being done like that, repeated nasal sprays can traumatize the nasal mucosa and give rise to small ulceration and bleeding. And the other is the cocaine abuse. And in our childhood days in the schools, we used to see our mostly the Telugu masters using this nasyam, they used to call that, because nose is very vascular. These when they apply this to the nasal cavity, nose, the blood vessels that are present there absorb this material, and and they give their whatever is the euphoric effect. So these are the various local conditions that we have to consider, and then we go to the general causes, which are usually, as I told you, the hematological conditions, where the coagulation of the blood when there is an injury doesn't happen, and so these are called the coagulopathies, like the hemophilia, and the platelets, role of platelets, and in leukemia the number of cells are there, but they are not mature enough to do the clotting mechanism, help in the clotting mechanism. Then you have the platelet dysfunction conditions like von Willebrand's disease. Then you have the the environmental high temperature. High temperature, what happens is there is dryness of the the nasal mucosa, and so anything dry is said to be dead. So there is some kind of a tissue damage that occurs and small ulceration, and then it leads to bleeding. Then high humidity, the altitude, these are the other environmental conditions which contribute to the epistaxis. Then you have these drugs, the anticoagulants and heparin, warfarin, which are used to prevent the blood clotting, and there is some antiplatelet aspirin and clopidogrel which are used by the elderly people who have a tendency to have clotting. To prevent, these are the drugs that are used, and so they are the ones, they may not initiate the epistaxis, but if there is a small rupture, the bleeding continues because they are the ones which are which do not allow the blood to clot. And of course the organ failure wherein you have the uremia and liver, which produces the vitamin K, and so that is one of the factors which in the cascade of the blood clotting mechanism. Then others, of course, the atherosclerosis, hypertension and alcohol. Then we just try to understand the blood supply of the nasal cavity and the paranasal sinuses, particularly the nose, the medial and lateral wall. Of course, the entire body is supplied with the blood, but if you see in the nasal cavity, entire mucous membrane, submucosally, there are blood vessels. But there are two areas in the nasal cavity which are prone or for bleeding. They are called bleeding area of the septum, which is called the Kesselbach's or the Little's area, which is just behind the mucocutaneous junction on the septum. And there is another area which is called the Woodruff's area, which is just behind the middle turbinate in the lateral wall of the nasal cavity. These are two areas which are flooded with a lot of blood vessels. There is a kind of a junction of these blood vessels they form submucosally, and these are the areas where the bleeding, if it starts, continues for a long time. And these are the areas we should look for in case of bleeding which is occurring and repeating itself. Okay? So we'll study about these two areas, and we'll see. And this is the Little's area, as I told you, on the septum. Okay? And the blood vessels are the anterior ethmoidal, the posterior ethmoidal, the sphenopalatine artery, and the greater palatine artery, which runs in the oral cavity, and then through incisive foramina it comes here, and of course the facial artery, which divides into the upper labial artery and a branch which supplies them. These are the ones which conglomerate here in the anterior part of the septum and give rise to, if there is a trauma, usually nose pricking, that can give rise to bleeding from the Little's area, which is otherwise called the bleeding area. Then we go to the other area, the common areas of causes of epistaxis. We have read so many of these conditions, local conditions. We have seen the various congenital and the systemic conditions, but they are all not very common. The commonest ones are the child nose pricking and the foreign body and exanthematous fevers like the measles, mumps, and the adolescent, usually the nasopharyngeal angiofibroma, or trauma. Trauma is common for all. And sinusitis, the inflammatory conditions. Adults, of course, the sinusitis and trauma once again. And elderly, same trauma, hypertension, malignancies. These are the common causes. So when somebody comes with a complaint of epistaxis, look for these common conditions. And most of the time, 80% you are right. But there are always these conditions which are rare, which require some kind of a investigative procedure. So broadly, how we should manage if a patient comes to you with a history of or bleeding from the nose. This is called the epistaxis. This is another diagram which roughly tells you. As I told you, the nasal septum, this is the perpendicular plate, this is the vomer, this is the cartilage. And so this is the nasal septum. So this is the area where you have the junction, as I told you, various vessels, anterior, posterior ethmoids, and this palatine artery, greater palatine artery coming by that, superior labial artery branch coming into this. That's one. And the second one is the posterior. This is the lateral wall of the nasal cavity. This is the septum, and this is the lateral wall of the nasal cavity. There it is, the bleeding can occur. This is called Woodruff's plexus, wherein you have the sphenopalatine artery, the anterior and posterior branches, and of course the venous blood vessels along with the arteries. This is the cause. This is posteriorly situated. This is the middle turbinate, which is the middle turbinate, just behind the middle turbinate area. So that is called the Woodruff's plexus. So this you must try to understand. The anterior is the Kisselbach's and the posterior is the Woodruff's. Now if you consider the commonest cause of bleeding is anterior, whereas the posterior is not very common. This is usually found in the young people, and this is elderly people with hypertension. And this is anterior bleeding, this posterior. There is a small chart which is given here. This tells us this is more common, the anterior epistaxis, whereas the posterior epistaxis is less common and easy to localize because anterior rhinoscopy is simple examination with a nasal speculum. It is easy. Whereas if you have to identify a bleeding which is behind the turbinate, anterior rhinoscopy doesn't help. You have to do a nasal endoscopic procedure. And common area, as I told you, Little's area, and this is the Woodruff's plexus posterior. And this is in children, people, younger people, and this is in elderly people. And trauma is the commonest cause, and here the hypertension. The treatment usually is simple anterior nasal pack, whereas here the posterior nasal pack, which is a little difficult maneuver to the posterior. We'll see how the packing is done and how the bleeding is controlled. Then we go to the general evaluation of the patient with epistaxis. When the patient comes to you, you should find out how did it start and how much is the bleeding, duration, on and off, the frequency, the amount of bleeding that is occurring, is it the right side or left side, and is there a previous history of bleeding. This is very important for you to assess the kind of bleeding that you are dealing with. Then you have the nasal trauma, so you should inquire if there is a history of any hot discussions at home or in the schools. Usually in our days, I think we used to have punishments. My teachers used to slap, but nowadays that is gone. So the trauma is usually at a roadside accident or games, things like active games. Then of course the purulent nasal discharge, which says that there is a infection, acute infection. And in the acute infections, what really happens is the blood vessels become friable, and so a small amount of blowing out of these secretions can traumatize those blood vessels and start bleeding. Then of course the hypertension per se, hepatic diseases and bleeding tendencies, anticoagulants usage, the aspirin, particularly elderly people with cardiac problems. These are the ones, as I told you, they are not the cause for epistaxis, but when there is a bleeding, it is increased twofold or fourfold because the bleeding doesn't stop. Then how do you evaluate these patients when the patient comes to you? The most important thing that you have to do is the pulse and blood pressure, and of course the hemoglobin, packed cell volumes, hemoglobin, blood grouping and cross matching, so that if there is a requirement we might have to transfuse blood depending on the loss of blood, and the bleeding time and clotting time to see if there are any conditions, deficiency in the clotting mechanism. Then the activated partial thromboplastin time, prothrombin time, the platelet counts, some of the viral fevers, the platelet count comes down, and so they have a tendency to bleed. The diagnostic nasal endoscopy is another procedure which can be done in the outpatient, wherein you can see the sometimes the area where there is a small sputter or that is you can identify. And then the CT scan of the paranasal sinuses, wherein you would like to see if there is anything bleeding from the paranasal sinuses, or when there is there a tumor there or any other swelling. So these are the ones basic investigations which help you to find out where exactly is the bleeding point. Then general treatment, of course, as the patient comes to you, there are two things that you need to do. One is to stop the bleeding. Then at the same time assess the amount of bleeding that has already taken place, so that you may have to replace the loss of blood, or management of shock. Shock is something which has to be parallelly looked for, because it may be a mild, moderate or severe shock. Mild shock, the pulse rate increases but the blood pressure is maintained because the extracellular fluid comes into the intravascular compartment. Whereas if the bleeding continues like that, then the blood pressure slowly falls down. Then after the blood pressure falling, even if the bleeding is much more than there are various other manifestations of severe shock, and how do we assess is the catheterization and urinary output has to be measured. So these are the various things that you have to do parallelly, and at the same time try to control the local bleeding. So you are treating, stopping the bleeding that is arising, that is in the nasal cavity by various procedures we'll discuss. And the second thing is assess the amount of shock, so that also has to be attended to parallelly, and start with IV fluids and some plasma expanders or sometimes blood. So and then you have the adequate sedation so that the patient is not very apprehensive and doesn't go into the panic state. Then of course the styptics that are used, the antibiotics, the antihypertensive medicines, all this. Now this is the general chart which tells us when the patient comes to you, you should first try to assess the shock, assess the location of bleeding. If you know where the bleeding is occurring from by doing an endoscopy, you can either cauterize, okay, and if you cauterize, if you identify the visual bleeding point, cauterize, or if you are not able to identify this local small point, if it's a kind of a diffuse bleeding or the patient is not cooperating, then you have to do an anterior nasal pack. If it is, and with this anterior nasal pack, even then if the bleeding is not getting controlled, we go into a pack which is called the posterior nasal pack. Anterior nasal pack, as we said, controls the bleeding from the Little's area, anterior, the anterior pool of blood vessels in the Little's area region. But if the bleeding is from the posterior, then you have to apply a posterior nasal pack. We'll see how that is done. And even with the posterior nasal pack, if the bleeding is not getting controlled, then you have to think of the surgical procedures wherein you try to identify which is the bleeding point, bleeding blood vessel. You can wherever you can identify with minimal morbidity, you can identify this and close that bleeding point. So this is the gist of the management protocol of the nasal. We will come to this in the end when we summarize. Then of course the conservative treatment, as the patient immediately comes to the OPD, first thing that you have to do is applying pressure to the nostrils. Now whenever there is a roadside accident, suppose there is an injury to the arm, there is a bleeding. So you just have to put pressure there. First thing is the pressure. Then and maybe put a bandage so that with that pressure usually the bleeding stops. Suppose it's a kind of an arterial bleeding where the artery is cut. So the bleeding may persist, but that is the minimum basic first aid that you need to do. Then you can take the patient to bring the patient to the hospital, wherein you can think of managing the other methods of controlling the bleeding. Now there are conservative methods are the chemical cautery or electrocautery, the vasoconstricting agents, the cryotherapy, and anterior and posterior nasal packs. These form the conservative management of the epistaxis. After that, as I told you, if the conservative procedures control the bleeding, you put the anterior nasal packs, and then when you remove the packs, it starts bleeding again. And with the anterior pack, it is not getting controlled. Posterior nasal pack temporarily controlled, but when they are removed, it starts bleeding again. Then you have to think of the surgical ligation procedures of the internal maxillary artery or sphenopalatine artery, or sometimes the extracarotid artery, and the ethmoid arteries. Now that we know the blood vessels which supply the nose and the paranasal lateral wall of the nasal cavity, we know how they come into the nasal cavity, so we can address them either as they are entering into the nasal cavity through an endoscope, or sometimes just before entering into the nasal cavity where they are in the sphenopalatine retromaxillary area, you can approach the maxillary artery. Maxillary artery is the major artery. Sphenopalatine branch is the major blood supply. You see, it's about 60 or 70% of the blood supply is from that. So that is the one which you need to attend to. And the endovascular embolization of the arteries, where you have a good radiologist and you have the facilities of doing the embolization procedure. Now we will go to that shortly. So the first method, as I told you, pinch the nostrils plus ice pack. Okay, put some whatever is handy, cotton or gauze piece, and put pressure. And there is a procedure which is called the Trotter's method. Now, Trotter's method is a method which comes in the first aid of the bleeding. You just have to pinch the nose bend a little forward. Okay, don't lie down. You just have to sit, bend down, and pinch the nose, in the sense all the cartilages part, the upper and lower alar cartilages are pressed, so that they put pressure on the septum. That is the area where usually the common area of bleeding, in the little's area. So the procedure is sit down, put your head down, and pinch the nose. And how long do you pinch the nose? It's for 5 minutes minimum. So after 1 minute, don't try to take it out and clean. It starts bleeding again. So you should religiously hold it for 5 or 10 minutes. And meanwhile, how do you breathe? Breathe through the mouth. So this procedure method is the one which can control most of these bleeds, because as I told you, most of them are anterior bleeds. So Trotter's method, you should remember, it may be asked as a short question. Then small, suppose anterorhinoscopic examination, you find there is a small injury to the either to the septum or to the turbinate in the nasal cavity. This can be easily cauterized, a chemical cautery, silver nitrate or copper sulfate sometimes. This is what we used to do. Now we have the electrocautery. So gentle cauterization can control these kind of small bleeders. Then we go to the nasal packing. We used to have long ribbon gauze packs with the liquid paraffin and antibiotic cream. The Vaseline gauze, which are they are made smooth, so that they don't traumatize as you are packing the nasal cavity. They don't traumatize the nasal mucous membrane. And Merosil tampons. Now these are the methods wherein you can do the nasal packing. But if you are in a town or a city, you have these Merosil compressed gel foams, which are readily available, and they are very easy to insert, and with minimal trauma. And there are some other apparatus or equipment with which you can control the bleeding. Now we'll see those. So the basic thing. Now these various other things, the Merosil pack or the other gadgets may not be available in the village atmosphere. So you should be prepared to control the bleeding at that rate. So ribbon gauze is the standard procedure wherein you pack the nasal cavity, and this is called the anterior nasal packing. Usually this controls the bleeding. And then we go to the when you do the ribbon gauze nasal packing, both the nasal cavities are packed tightly, and they are removed after 24 to 48 hours. Meanwhile, systemic antibiotics given to prevent sinus infection and toxic shock. I'll tell you about these toxic shock syndrome. And this is what is the Merosil. It's a compressed gel foam which is stiff to start with. So you just have to take that and slowly introduce into the nasal cavity. And as you know, the nasal cavity is parallel to the hard palate. It should not go up. It should go parallel to the hard palate. And you introduce that, and then you can inject normal saline into this, and this compressed gel foam absorbs this and then swells up and to produce enough pressure on the nasal mucous membrane to control the bleeding. These are very easy to manage. It doesn't require a lot of expertise. Now there are various other equipment that have been lately developed, and these are nothing but the nasal balloons. just like the endotracheal, cuffed endotracheal tubes. Now nasal balloons are introduced basically, that is the one which is introduced in nasal cavity, and you introduce air into that. And so till there is adequate pressure on the nasal cavity, the septum, and the bleeding gets controlled. Then you have this is as far as the anterior nasal packing is concerned. Then we go to the posterior epistaxis. Posterior is the cause is the cause is traumatic, usually situated in the posterior part, which is called Woodruff's area, and this is situated just behind the middle turbinate in the lateral wall of the nasal cavity. Once again, I would like to repeat. This is present in the lateral wall of the nasal cavity, just behind the inferior turbinate, whereas the Little's area is present on the septum, that is the medial wall of the nasal cavity. Then, now the postnasal, this is what we used to do, postnasal pack. This is how we used to make the postnasal pack. And then we used to introduce a nasal catheter through the anterior nares and allow it to come into the nasopharynx and oropharynx, catch that in the oral cavity and the oropharynx, take it out, and then tie this to that catheter and pull this into the nasopharynx. Pull this into the nasopharynx. This is what it is. This is the posterior nasal pack. Initially, you just pass the nasal catheter like that through nasal cavity, nasopharynx, then into the oropharynx, catch it, and then pull it out through the mouth. Then you tie this post-nasal pack, and then slowly manipulate with your finger from the oral cavity into the nasopharynx, which gives adequate pressure on the Woodruff's area that we have mentioned earlier. That is called the post-nasal packing. With this post-nasal packing, you always do a anterior nasal packing also. Anterior nasal packing, so that the entire nasal cavity is packed. And this is the one which controls initially the bleeding. Now, some people use Foley's catheter, which is handy. All that you have to do is just pass the Foley's catheter just like this. Foley's catheter itself, it has got a bulb there. So you pull the Foley's catheter, inflate the bulb, and then slowly maneuver into the nasopharynx, where you can see this is how it is maneuvered into the nasopharyngeal region, nasopharynx, and into the posterior aspect. And ultimately you have to pack the anterior nasal packing also to control the bleeding totally. Now there are other balloons that have been described. If they are handy, you can use them. This is called nasal balloon, epistat. And there is another equipment which is called Bivona triple lumen catheter. Okay, and when it is introduced into the nasal cavity and inflated, this is how it looks. This is the posterior postnasal pack or postnasal area, and that is the anterior packing. So it is made simple, but this equipment has to be present. Now, what are the complications? See, you do the nasal packing. And how long do you keep the nasal packing? For a short period, maybe 24 hours, 48 hours. If it is non-irritant, maybe you can use it, you can keep it for 4 or 5 days. Ultimately, you have to take it out. If you can't leave them permanently there. So when you take them out, always look for bleeding again. There is a recurrent bleeding in spite of the anterior and postnasal packing. Then, as I told you, we have to go into the surgical procedures. Before that, let us study the complications of nasal packing. If you keep the nasal cavity for 10 days, 1 week, 10 days, what are the complications? Now, the first thing is the toxic syndrome. As I told you, the meroceal has got a tendency to absorb. They absorb. These meroceal, when they absorb, if they are retained for a long time, some kind of an infection occurs which can give rise to severe septicemia. So that is called the septic shock, which is not very common, but still it is known to produce when the tampons, these kind of packing material is introduced into the nasal cavity. Then these, as we see, the nasal cavity, once it is filled, the sinuses, various sinuses, the anterior group and posterior group of sinuses we read, the maxillary sinus, the frontal sinus, the ethmoidal sinuses, and the sphenoid sinuses, all of them open into the nasal cavity, and nasal cavity is blocked, and so their openings are also blocked, and so there is a tendency for the mucus accumulating in the nasal cavity and the paranasal sinuses, and give rise to what is known as the acute sinusitis. Sinus drainage is blocked, and so give rise to sinusitis. And as you know, the inferior meatus, there is a duct called nasolacrimal duct, and this is blocked, and so they have this epiphora. Sometimes the retrograde infection can lead to dacryocystitis. Then, of course, the nasovagal reflexes during insertion of the pack. Sometimes there is a nerve stimulation, and then suddenly they may go into bradycardia, hypotension. That can be managed in a hospital by making the patient to lie down flat, and whatever primary care has to be taken. Now, of course, during sleep, because of the nasal obstruction, the sleep apnea occurs, and the displacement of pack sometimes when it comes into the oral cavity and then descends down, it may obstruct the food going in or swallowing, and sometimes may irritate the producing airway obstruction. Then these are the complications of a nasal packing, so you cannot leave them for a long time. And when you remove the nasal packs, the next method you should be prepared if the bleeding persists. And these are various procedures which are called, basically grouped under arterial ligation. And we have seen the maxillary artery is the artery which gives off a branch which is called the sphenopenetrant artery, which is the major source of blood supply to the lateral wall of the nasal cavity as well as the septum. Then you have the anterior and posterior ethmoidal arteries, which have their contribution, maybe 15%. So our aim is, and of course the facial artery in the form of it's a very small superior labial artery, giving rise to the junction, the blood vessel which supplies the Little's area anteriorly. That's a very small contribution. So your idea is to tackle the major blood vessel, that is the maxillary artery, and sphenopenetrant artery, which is a branch of the maxillary artery, and this maxillary artery in turn is a branch of the this is what it is, the common carotid artery, which divides into the external carotid artery and the internal carotid artery. The external carotid artery gives off various branches, the superior thyroid, then of course the ascending pharyngeal artery, the lingual artery, then this is the facial artery, and then as it goes up it gives rise to the maxillary artery and the superficial temporal. Now this maxillary artery has to be ligated. So initially in order to let me see. Okay, initially surgeons were familiar with the neck surgery, and so they were and easily approachable. So they used to make a cut in the neck and then identify the external carotid artery and ligate the blood vessel as far as high as possible, if they can leave the above the lingual artery branch, they can ligate there. Okay, so that is what was done, and of course this is another diagram which says this is the external carotid artery with various branches, and the main branch is the internal maxillary artery, and how it supplies the sphenopalatine foramina and how it supplies the nasal cavity. Okay, and so this is what is done. Incision in the neck, you identify this is the common carotid artery, and this is the internal carotid artery, and that is the external carotid artery. External carotid artery is usually identified by its branches, whereas the internal carotid artery doesn't have any branches. That's how you identify the external carotid artery, and go as high as possible and ligate the external carotid artery. This is what was the procedure that was done. And then later they found because there are other blood vessels which are also blocked by the lingual artery, posterior auricular artery, the superficial temporal artery. All these vessels are unnecessarily blocked. So they said, why can't we selectively go and identify the maxillary artery? And this can be approached by a Caldwell procedure, wherein you open the anterior wall of the maxillary sinus by sublabial approach, and then that is the anterior wall, and that is the infraorbital nerve, and so you make a window in the anterior wall, and then you go, this is the maxillary sinus, and you go directly straight into the posterior wall of the maxillary sinus, and you open that also, and you go into a the maxillary, retromaxillary space, where you can easily identify the maxillary artery, and you identify the maxillary artery and do the ligation there. So this is more selective than the external carotid artery ligation. So this slowly has taken over the external carotid ligation. Then, with the advancements of the endoscopic procedures, we can directly visualize the sphenopalatine artery as it comes. Sphenopalatine artery is the one which is situated, which comes out through the sphenopalatine foramina, and this foramina, anatomically we know, is just behind in the lateral wall of the nasal cavity, just behind the middle turbinate, just behind the middle turbinate. Let me try if I can orient you to that. There's a diagram which I would like to show. This is the one. See, this is the, as I told you, the external carotid artery, and that's the maxillary artery. See how the maxillary artery, how it is coming into the sphenopalatine foramina. That is the sphenopalatine foramina, and the artery goes into the through that into the lateral wall of the nasal cavity, and this is where it is. The sphenopalatine in the lateral wall. That's the middle turbinate, and that is where the sphenopalatine artery comes into the nasal cavity, and there is a you can identify this sphenopalatine artery locally, and then by the endoscopic procedure. Yes, endoscopic procedure, you elevate and you can identify this, and you can clamp this sphenopalatine artery, and that usually controls the bleeding which is coming from the sphenopalatine artery, major part of the blood supply to the nasal cavity. So this is the surgical procedure. Sometimes if you every surgical intervention has got its own plus and minus. There are some complications, the chance for complications. So if you're not very familiar, there is another non-invasive sense, non-surgical procedure, which is nothing but the embolization. You would like to block that blood vessel. Since the technological advancements that have taken place, you can pass a catheter through the carotid artery, external carotid artery. You go like that and then go into the maxillary artery and the sphenopalatine foramen area. You can inject certain material to block this blood vessel permanently. So this is called the interventional radiology. And before that, you do a procedure called the angiography to know where exactly is this bleeding occurring, and the embolization. And there are various procedures, various material that are being used in the embolization. Ultimately, the purpose is to stop the block the blood vessel, because through this procedure, which is much simpler than the surgical procedures with its complications, this is a very simple procedure, provided you have the facility of this. And so you pass a catheter and then there you inject the material which blocks the sphenopalatine artery. And there are various embolic agents that have been described. We will not go into the details, but anyway, if you want to temporarily block them, you have the gel foam, the collagen and thrombin. If you want to permanently block them, there are various agents that are present. The liquid agents are the glue, onyx, alcohol, algel, things like that. And there are some coils which can block. Okay, and there are some detachable balloons. So various material are present for us to block that sphenopalatine artery with a good intervention radiologist. So this is how you manage the bleeding from the nose, which is called epistaxis, the conservative methods. And ultimately we come to the final summary. The first thing is you have to assess where exactly is the bleeding, and also assess the amount of bleeding, that has already occurred. And so you have to take that and manage that level of shock. And this nasal examination, if you can visualize the bleeding point, you can either cauterize, and or if you are not able to identify a single point, then you can do the nasal packing. So the nasal endoscopy is the one, and as I told you, there are two areas which you should look for. One is the Little's area, which is otherwise called the Kisselbeck's area. The second one is the of course the Woodrop's area, which is behind the middle turbinate. Then if there is no active bleeding or sputter that is seen there, then you have to do the anterior pack. If the bleeding still occurs, then you have to do the posterior nasal pack, and you cannot retain the pack for more than maybe 2 days, 3 days or 4 days, depending on the material that I have used. And there are complications, as we have discussed, the complications of nasal packing. So when we remove them, if there is bleeding still occurring, you should resort to surgical procedures, wherein initially the external carotid ligation, then followed by another procedure where you do a Caldwell-Eck and go to the posterior wall of the nasal maxillary antrum, and then ligate the blood vessels there, the maxillary, identify the maxillary artery, and then we have the sophisticated endoscopic procedure wherein we have seen how the sphenopalatine artery can be identified as it is emerging into the nasal cavity from the sphenopalatine foramina, which is situated. It's a beautiful landmark just behind the middle turbinate, and put a clamp to that. And with all these surgical procedures, there are some complications, and if there is a good intervention radiologist and with a facility of doing angiography, you can catheterize the maxillary artery and then go up to the sphenopalatine artery and block that with various procedures, various material that are present, and permanently they block so that the bleeding is stopped. So these are the various procedures that are present in order to control the symptom called epistaxis or bleeding from the nose. At the same time, when you control these, you should also, if there are systemic problems, they also need attention, and you should try to control the causes, various causes of bleeding. For example, there is hemophilia, then you have to control that, and there is a platelet formation, the problem, then you have to replace with the platelets. So these are the various, in addition to the general, locally these are the measures that are done, but there is a systemic problem that needs to be attended to. Just go through these videos again, once again, and if you have any doubts, you can get back when you come back to the college. Stay safe at home and take care of your health. Okay, bye.